As already discussed in depth by Dr. Vashne regarding applications of Holmium laser, I will just be focusing on the techniques in short for the want of time. The instruments that we are all familiar with, all the talks and all. What I want to tell is that initially important is a cystoscopic evaluation of the prostate to study the morphology of prostate, see the lobes, whether they are 2 lobes or 3 lobes, and take the advantages of the naturally existing grooves in the prostate, which can be incised, deepened, and the lobes can be manipulated. So the technique of the enucleation will be decided whether it is 2 lobe or 3 lobe to start with based on the anatomy of the prostate. And we should always spend more time, maybe initial 5 minutes, to study the anatomy, see the lobes, see the grooves, and then plan our incisions accordingly so that we have a good enucleation at the end of the surgery. In a classical 2 lobe technique, which is normally 3 lobe technique which is recommended, the first incision is at 5 o'clock, which starts from the bladder neck area and it continues down till the verumontanum. It is important that it should be incision deep enough till the capsule. It is very easy to realize and recognize the capsule by its circular fibers. Here we can see the bladder neck, which is already seen there. And once we make an incision, it is important to deepen and widen it on both the sides so as to have a good trench. And this makes the further enucleation simpler. Once the 5 and 7 o'clock incisions are taken, they are joined in front of verumontanum, and then the median lobe is lifted with the help of a resectoscope beak, and then we undermine this lobe staying on the capsule and push the lobe in the bladder. This is whitish tissues are all prostate that we can see, and once we cut that, we can see the circular fibers. This is how the median lobe finally is enucleated, and it is still attached only at the bladder neck level, and by further lasing it will be detached and it can float free in the bladder. Once this is done, important is the apical enucleation. The groove which exists between the apical tissue and the veru has to be deepened. There is always some oozing and bleeding in this area because of the submucosal vasculature, which has to be ignored. Once we cut the mucosa, usually we can go into the capsular plane with 1 or 2 cuts, and once we enter that proper plane, then a blunt dissection, as you can see here, will gradually separate the adenoma from the capsule. The vessels which will be encountered can be taken care by defocusing the laser beam. This is how we are peeling it off with the mechanical dissection. On the right hand side towards me is the adenoma, and here we can see the capsule. This is how the apical tissue will look like at the end of the enucleation. In few prostates which are big, we may have to go almost 2 centimeters distal to veru to really enucleate the apical tissue completely from the splinter. It's important to do that and not to cheat through the tissues so that we don't get lost in the tissue or lost in the prostate to start with. After this is done, then 12 o'clock incision is taken. There is hardly some tissue there, so 1 or 2 incisions usually suffice. And once we take an incision, we have to follow the capsule and bring the adenoma down, staying on the capsule. As we keep on separating the adenoma from the capsule, we can see the adenomatous tissue falling down. We can see here above the capsular fiber circular and the adenoma dropping down. And the length of incision keeps on increasing as we approach down and down to take care of the apical tissue. Once this apical incision is done, then the next step, an important step, is to have this anteroapical attachment. There is a strip of mucosa which is connecting the lobe now near the splinter. We need to come at the level of splinter and identify this mucosa strip, lower the energy to 20 or 40 watt. Just cut the mucosa superficially, and once the mucosa is cut, automatically the lobe is disconnected. This is the final appearance of the fossa at the end of enucleation. It is always a wide fossa, but it may not be very clean. It appears that surfaces are rough or irregular, but this doesn't really make any difference in the outcome of the patient. This is followed by morcellation with a morcellator. Most important thing is to have a clear vision, a good hemostasis, and absolutely distended bladder by using both inflow and outflow of the nephroscope to fill the bladder, because morcellator itself has a suction which will suck the fluid out of the bladder. Normally I put a zebra wire and put a catheter on the same. Although irrigation is and traction is not required, I usually give a mild traction and a slow irrigation as a safety, because we don't really remain with the patient all around, and after we leave the patient we don't want any problems. So as an added safety usually I do it, but it is not really advised, means not recommended in all the patients. This is another video showing the extent of apical tissues and the splinter relationship that we can remove, and this can be as far distal below. I have also done thulmium enucleation, and what I found is that it is really difficult to get into a proper plane between the splinter and the apical tissue because of the charring of the tissue, and doing such amount of distal dissection is really challenging with that laser. This is just a slide showing, or a movie showing, a capsular perforation with the fat seen here. Doesn't really bleed a lot, and absorption being a normal saline doesn't cause any TUR syndrome. And all the bladder perforations are all superficial mucosal, they are also rare, and usually they don't cause any change in the post-op management. So basically morcellation injuries are not so common as thought of, and not of any major significance at all if we follow the principles of morcellation properly. This is a superficial mucosal blight we can see here. Even recurrent prostates, we need to study the anatomy and deal them accordingly. Bladder stones of any size can be dealt with this laser. Being a high power laser, larger stones can be treated rapidly by using higher energy. We can go up to 60 or 80 watt. This is how the slow energy of 10 watt will do on the bladder. It's just doing a small job, and it's a very time consuming thing to continue with this low energy. But the moment we increase the energy, we can see the difference. It really makes a deeper holes, and the stone gets fragmented completely. And at the end of 20-30 minutes, this 4 cm stone will be converted into a dust, fine dust, which will settle at the bladder and will easily come out. So we don't spend a lot of time in removing the fragments. The mucosa appears quite normal in this treatment at the end of the procedure. It's also good for impacted ureteric stones. Usually if there is any mucosal overgrowth on the stone, that can be taken care by ablating it with the laser. And the stone, usually I like to paint it all across so as to decrease the length of the stone and keep it impacted throughout, so that the chances of it getting dislodged in the proximal ureter or pelvis are minimum. Another soft tissue application is endopilotomy. This is the ideal pelvis to be treated by endopilotomy. Otherwise, nowadays, as Dr. Anand Kumar told yesterday in the symposium, the indications of endopilotomy per se have decreased. But especially if there are multiple stones in the kidneys and such type of small pelvis, these patients do extremely well even in long term with a proper endopilotomy. And the advantage of laser again is the precise nature and a good hemostatic effect. This patient had multiple matrix calculi which were initially removed. We can see a small PUJ with a ureteric catheter across. I do use resectoscope with a laser bridge from above through Ampla sheath, and to make it watertight we usually use a nipple of nephroscope or laparoscope to seal the Ampla sheath. With a laser energy of around 10 watts, we usually cut the fibers. We can see each and every fiber separately, cut it precisely. What we do is exoendopilotomy. We cut the pelvis first, go out in the retroperitoneum, see the ureter from outside and cut the wall of ureter from outside. This is the way we safeguard against damaging any crossing vessel and causing any major complications. We can see the vessel here, we can stay away from it and just cut the ureter from outside in. Once a proper adequate cut is made, then again we switch over to a nephroscope and put a endopilotomy stent across this incised PUJ under visual guidance using a nephroscope. Same thing can be done from below, either with rigid or flexible ureteroscope. I will split this movie. It is again good laser for post TUR or open prostatectomy bladder neck stenosis. Here we not only incise the fibrous tissue, we can vaporize it and resect it also, so as to make a very wide cavity at the end of the procedure. This patient had an open prostatectomy and a very narrow bladder neck. So we are basically cutting the fibrous tissue. The advantage of laser over cold knife is that we can resect that fibrous tissue and keep a supple tissue behind, so that the chances of restenosis probably will be less, although there is no head-to-head comparison. But to my personal experience, we have not seen any patients coming back for restenosis. No patients need dilatation or calibration, at least after bladder neck thing. They do need after a stricture urethra surgery. Sometimes we can come across a residual adenoma tissue which can also be enucleated or resected, so that we can do a good job for the patient at the end of the procedure. It again carries all advantages of lasers, safe in anticoagulated patients, less bleeding. Here I am just removing the extra tissues and making it wide enough. At the end of this, we purposefully cut the capsule till we see the flat, so as to release the complete tension on the tissues. Here I am cutting the capsule purposefully and deliberately, so that the things become wide open, and this will minimize probably the chances of restenosis. The same thing can be done for post radical prostatectomy bladder neck stenosis. This is what we do for strictures. We ablate the stricture circumferentially, resect all the adenomatous, fibrous tissue all around, to leave a supple spongy tissue behind, decreasing the chances of probable restenosis. Again, the bleeding is very minimum, and initially we incise the tissues till we see spongy tissue, and then we try to resect the fibrous tissue. I don't know why it's not running. This really gives a big area there inside. The flow rates improve well. I usually like to ask the patients to do CIC after this surgery for at least couple of months to a year. We are actually resecting here the fibrous tissue all around. And we can see that the bleeding is almost negligible at the end of the surgery. The results probably might be superior to VIU, but definitely may not be as good as urethroplasty. Thanks a lot.